Good morning, everybody. Everybody awake? I want to thank the Genetic Alliance for hosting this really important meeting and pulling a lot of the stakeholders together. You know, for those of us who kind of have traveled for a while in the newborn screening arena, you know, I often describe, at least the previous Secretary's advisory meetings, as kind of going to a Thanksgiving, you know, where you kind of know people for a long time, and that's a wonderful thing. A very diverse group of people, but this is actually a real shakeup. This is a group of people, some of whom are very familiar and some not. So I think this will be inform the elements for a very exciting day on an important topic that's been, I think, in many of our minds for quite a while. So, so thanks to Natasha and the Genetic Alliance for allowing me to participate. Okay. All right. So I was asked to start the meeting, which is kind of an interesting task. Don't know whether to be straight or very provocative, so I'm going to try to be a little bit of both. And this is the outline of my talk. I'm going to give an overview of newborn screening for those of you who are less familiar with it, and for those of you who are very familiar with it or even recognize the slides, you'll forgive me. Mention the impact of technology on how newborn screening has progressed, and you know, I think about newborn screening as kind of a roadway, and whether we go fast or slow is kind of the theme of today. So I'll try to describe that, and then you know, thinking about this expansion, it's always been part of newborn screening. You know, what's pushing forward, what's pushing back, and then make some of my own comments. Okay, so. Just to remind people who don't already know that newborn screening is a system where there's a lot of collaboration across many different functions. So there's the hospital where the specimens, babies are born, and where specimens are collected. There's the actual blood spot. Maybe I'll do this. There's the blood spot. Well, whatever. The samples get sent to the state lab where they're processed at scales that are just sometimes really always staggering to me when I think about, I mean, New York State, which I'm going to speak from that perspective a little bit, you know, processes 250,000 samples a year. So if you do that, the math by the day, which I can't do standing here, it's just staggering. Anyway, the lab program you know, has to communicate results in a timely fashion to the hospital, to the primary care provider, in some instances to the consumer, as well as to the specialty center. That's where I live. For those of you who don't know, that's the Hudson River. And then the child has to be seen by specialty care for diagnosis and treatment. And then somewhere in that, to some extent, I understand and some I don't, the electronic data and record system for accounting in this system for short and long-term follow-up. So I'm going to say that this is where I am on newborn screening. This came from a newborn screening task force report in 2000. This was really a collaboration between HRSA and the American Academy of Pediatrics. And while it's now aged, it's aged well, I think, this report, and worth going back and looking at the elements of that report. But certainly, in terms of its sort of summary, it's that newborn screening should be conducted only when science and technology can serve both the individual and the public good. And I would like to say that that's the platform upon which we are standing today. Okay, so what's the impact of newborn screening? This came from a recent CDC report. So approximately 12,500 children are diagnosed through newborn screening annually, and that includes over 5,000 with hearing loss. So that's about 7,500 children who are diagnosed with metabolic or endocrinologic or hemoglobinopathy. So that's a lot of children at the cost of approximately $30 per infant, and that's by 2003 data. Okay, so screening is based on phenotype, and that is to minimize uninformative results. Okay, so newborn screening has always been defined by available technology. So this is a slide from from Ken Pass, who used to run New York newborn screening and was a longtime collaborator. This is how he got these pictures. I mean, I had no access to them, but this is bacterial inhibition assay for PKU, and that brown thing on the left is just a wooden box where you could look at the results. Today, that's obviously no longer where we are. The labs are highly proficient, highly technologic. First, there's been mass spec over the last decade. Now, increasingly expanding capacity, and DNA-based analysis also has been introduced really for more than 10 years. Looking at Ann. DNA. 99, okay, in your program, 99, Massachusetts, okay. For specific mutations, like for confirmation for cystic fibrosis, more recently for SCID, severe combined immune deficiency, a functional assay, so that's in the last few years, thanks to May Baker. Is limited sequencing for targeted genes for confirmation, and we're here to talk about what's next, genome-wide or whatever. Excuse me. So there have always been new opportunities for newborn screening through discovery, new technologies, and therapies. I'm going to just mention for a few minutes the process by which states collectively decide what disorders to screen for in their panel. That's something that I've been involved with, and many people in this room have been involved with for the last years. So previously, disorders and screening panels varied widely between states, and several states, New York and Massachusetts, among them, Wisconsin, piloted screening for disorders statewide prior to adoption by other states. That's what pilot programs were. And then in 2005, there was a report by the American College of Medical Genetics that put forward the concept of a recommended universal minimum screening panel, or what's called RUSP, Recommended Universal Screening Panel. Their report was called Towards a Uniform Panel and System. And this, as I mentioned, established the first national recommendations on conditions to be screened by state-based programs. Through a process of selection, there was a set number of specific conditions that fit their criteria. And when this first was published, this really helped drive states to become more uniform in the disorders for which they were screening. And I think time has proven this concept to be correct in giving children more equitable access to the benefits of newborn screening with respect to screening panels. Now in 2000, the Children's Health Act of 2000 was authorizing legislation for an advisory committee on heritable disorders in newborns and children. There was additional legislation in 2008 for funding for outreach and for outreach. And there have been committee meetings since 2004, and they continue now, although the funding for the committee is in limbo, and so it's not clear what will happen in the future. Currently, the committee meets virtually for cost reasons. And I mentioned the Genetic Alliance. We should recognize that they've been very active in the committee and the efforts around the committee since its inception, and credit to them for really introducing a very important consumer voice that now we say, oh yeah, of course, but back then it was less obvious. So we should thank our hosts for that. So one of the major functions of the committee was to devise a nomination and review process that was evidence-based for nominated conditions. So there's a process to do that where the public or anybody can nominate a condition, and then the sort of the underscored aspect of that is that this is very thorough, careful evidence review. The process has been based on other accepted and widely used processes like the U.S. Prevent Task Force. So there's publicly available a nomination form with the appropriate elements, conditions, screening, test, and treatment, as well as references, again, because that really launches the evidence-based review. Then with a report drafted, the condition is presented to the advisory committee for discussion, consideration, questions, and the elements of the committee considerations have been that the condition is medically serious, that it's understood from population-based assessment, right? Because populations are different from clinic populations or clinic patients, and that assessment, both of the disease, the manifestations, and the screening is important. The screening test works on populations, diagnosis is possible, and that children those children who are identified through screening who need treatment are identifiable, and that the treatment is effective and available. Now, the committee also includes an aspect of public health feasibility and readiness, which I'm not going to talk about. So this is just an example for severe combined immune deficiency. This is data that the committee reviewed very carefully with the nomination of SCID and with the intervention of an early infant transplant younger than a few months of age. And this is really the data that I think, appropriately convinced the committee that SCID ought to be a condition added to the panel in addition to the screening and testing that was also pioneered at the time, but that the children who had an earlier transplant had a much more substantial survival than children who were identified later. So that's the kind of data that's important for making these kind of decisions, that early identification allows for treatment that's effective and available. Okay, so there have been a number of nominations that have happened, and as of May, there have been a number of conditions nominated. 3 have been recommended, as I mentioned, SCID, congenital heart defects, and Pompe disease. Most recently, several conditions have not been recommended because there are questions about the effectiveness of screening and or treatment, because while there may be convincing data at the clinic level, the translation to the population level has not been demonstrated. The committee did not feel that the translation to the population had not yet been nailed, had been proven to be effective. So what's coming in newborn screening, and what does that mean for those of us interested in newborn screening who participate in the deliberations, and us clinicians who then take care of kids who are identified through screening? Fragile X is sort of an example of conditions where treatment is sort of not classically medical, that there are early interventions, not clear what the benefit is to the affected child. Those are ongoing considerations. Spinal muscular atrophy, pending results of treatment trials, looking very promising, and there's some screening issues. Lysosomal storage diseases, and so from a pediatric hematologist oncologist, I can say that there's been there's been a number of lysosomal storage diseases that have been nominated, and you think that hematopoietic stem cell transplant is available, easy treatment. It's not true, and there have been fatalities associated with kids who were identified, like for Krabbe, who were transplanted. So I think that is I have the stage, and I can say that that's a very difficult risk-benefit analysis with considerable potential harms. And now we're here today to talk about whole genome sequencing from blood spots. So what's holding newborn screening back? Discovery, screenings, treatments, dollars, of course, for research, for public health. I don't have to mention that these are state programs that I guess to call them starved would be polite. So both at federal and state levels, there's resource issues. And the Federal Advisory Committee, as I mentioned, there are the reauthorization legislation and so issues, and so it's in limbo. And then there's public ambivalence. So this is a storage site, I think it's California, but I'm not sure, for dried blood spots, and you can see they're carefully stored in bags, climate controlled. There's thousands and thousands and thousands of them. But if you're looking at DNA, it's very stable on these cards, and it's really tremendous public resource for ongoing quality improvement for newborn screening, as well as discovery. So there are public-private controversies, and I don't want to get into that too deeply. But just as an example, arguments are always about resources and responsibilities. And so I think this is a perfect example where the Bloodspot specimens, they're used by programs, have always been used by programs, stored specimens for, as I mentioned, these essential functions to improve programs and to move the programs forward, and then privacy concerns from parents. And so there are consequences when the public feels out of step with those kind of decisions made by state programs for how to use those resources most effectively. And the consequences are that well known that Texas had to destroy over 5 million newborn samples, and Minnesota, I don't know if they've destroyed the samples yet or not, but it's on the chopping block. And the states have responded, I think, very appropriately to increase the outreach to parents about the importance of this Bloodspot resource. But to say it's wow, it's an unknown territory. Kind of the public health would again be we'll probably talk about that today. So from a clinician's perspective, how should newborn screening expand to better meet the current and future needs of children and their families? I mean, that's obviously not a simple question. Again, I welcome the discussion today, but I'm going to stick with the traditional and the task force report from 2000, which said the information should be useful to the child, the health of the child. So I did want to mention that in 2005, Ken Pass, who I mentioned was the former director of newborn screening for New York, and I published a paper on the use of now what seems like sort of yesterday's technology, microarray for looking at newborn screening. And there were considerable limitations that we raised in 2005, which are pretty much all still there. So this incomplete coverage of testing that's probably resolved with the new microarray and et cetera system for whole genome or whole exome. There's imperfect genotype-phenotype correlations, and that's still a problem. There's translational, there's environmental, there's epigenetic, there's all sorts of moderating factors which the microarrays or the new generation of sequencing is going to have a hard time with. It's the TMI, right? Too much information. Generates too much information. What do you do with the information? How do you communicate the information? How do you interpret the information? Right. And then there's, as I mentioned, there's the consumer-provider. There's the consumer-provider public health interface not worked out. So my own thoughts are that public health should serve the public, that the treatment and resources should be focused on new treatments, new diagnoses, and understanding disease modifiers, because that is really important. And maybe in the next generation of newborn screening will receive more attention as more is understood and testable around the disease modifiers, given that every disease is a spectrum, almost every disease. That research is intrinsic to newborn screening, but must also serve public health, and that these functions must be mutually supportive. So it's I think to me it's the TMI, and what risks are acceptable with all that information, interpretation difficulties, questions of parental autonomy, and the burden of information. I mean, even when states currently identify traits, cystic fibrosis, sickle cell, states vary in how they communicate that, and what their responsibilities are. It's not even clear. If you just send a letter to the hospital or send a letter to the parent, is that this program's responsibility? Maybe it is, but then what do you do then with a mountain of information that's traits and other, and how do you incorporate that into understanding the child's health, the family's health currently, and then going forward? So, but some things won't change. This is obtaining the sample. Now, of course, that's not true because we have point-of-care screening as well, but anyway, thank you very much.